Welcome, everyone, to today's webinar, Evidence and Empowerment Tools for Fostering VTE Prevention Champions. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We'll have a series of poll questions during today's webinar. You can submit the answer that best applies to you directly on your screen in the slides box. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's speakers, Tanya Hoyer, Critical Care Clinical Educator at Doylestown Health, Bill Nadeau, Global Director, Medical Affairs, Cardinal Health. Tanya and Bill, thank you so much for being here today. And Bill, I'll now turn the floor over to you.
Thanks, Brian. Hello, everyone, and welcome. Cardinal Health is delighted that you have joined our webinar on the latest evidence-based perspectives and blood clot prevention strategies aimed to cultivate VTE prevention champions. My name is Bill Nadeau. I'm the Global Director for Medical Affairs at Cardinal Health, and I'm very pleased to be a part of this important session, and now I'm delighted to introduce our speaker. Tanya Hoyer has been a registered nurse for almost 30 years. The last 20 of those have been spent in critical care. Tanya is currently the Critical Care Educator for Doylestown Health, just outside of Philadelphia. In her current role, Tanya works with multidisciplinary teams to improve patient care and update clinical policies and order sets. Tanya is currently working on a hospital-wide project to improve adherence to VTE prevention measures. Tanya is also working on a Master's of Science in Nursing Education. Tanya is passionate about VTE prevention and has, in fact, been working in her hospital throughout the COVID-19 pandemic. So without further delay, please help me virtually welcome Tanya to deliver this presentation titled Evidence and Empowerment, Tools for Fostering VTE Prevention Champions. Please go ahead, Tanya.
Thank you so much, Bill. And thank you, everybody, for attending today's presentation. As Bill mentioned, I am very passionate about VTE prevention, and some of the statistics that I'll show today might surprise people. And that's really the reason that I wanted to get more involved in VTE prevention efforts in my hospital. So full disclosure, I am a paid consultant for Cardinal Health, but my research was done prior to my relationship with Cardinal Health. So I'm just going to move right in. So our objectives today are to discuss actions necessary to create a best-in-class VTE prevention committee and locate the evidence that supports that committee, the resources that we need to support our decision-making. We want to identify techniques to empower all levels of nursing to be VTE prevention champions, understand some strategies needed to create an effective VTE prevention protocol, and recognize how you and your peers learn in this digital world, especially with the ongoing pandemic that we have with kind of a little bit more difficulty and challenges with learning. So I want to start very back at the basics, and I know most of you know this and you're well aware of this, but it's always good to have a basic understanding. So venous thromboembolic disease is defined as an abnormal clot in the vasculature from components of blood. That can be either pulmonary embolism arising in the pulmonary vasculature, or it can be a deep vein thrombosis. So either of those together is a component of venous thromboembolic disease. How do we get venous thromboembolic disease? It's through Virchow's triad. So this was identified in the 1800s by Virchow, who looked at why people would get clots. And it's three different factors: hypercoagulability, vessel wall damage, and vessel wall damage can be internal from having a plaque, or it can be external, such as trauma, or even through a venous catheter. And then our third part of Virchow's triad is venous stasis, which is immobility, and decreased blood flow. So decreased blood flow because of decreased blood pressure, or it can be from not moving around too much. So any one of these put patients at risk for venous thromboembolic disease, but we know that most of our patients in the hospital have all of these. They have a lot of imbalances going on with their coagulation systems, and they have those catheters placed, and they're in bed most of the time. So many of our patients have all three of these factors, which is why we really need to pay attention to VTE prevention efforts. Most of my talk is about adults, and more so adults in critical care. So I just want to put that out there, that my experience and research is in adult critical care arena, but I know that some of these can be used in other areas as well. So starting with statistics, this is directly from the CDC website, the Centers for Disease Control and Prevention. As many as 900,000 people are affected every year in the United States with venous thromboembolic disease. That creates 60 to 100,000 deaths. And unfortunately, in about 25% of pulmonary embolism, the first symptom is sudden death. So this is something that can take patients away very quickly without any way to get involved in getting the healthcare team involved so that we can prevent death. So really, VTE prevention is paramount to saving lives. It also arrives in $10 billion in healthcare costs. And there's a lot of long-term effects of thromboembolic events. If a patient has a VTE, a deep vein thrombosis, they are much more likely to develop another one in the future. And the same is true for patients with pulmonary embolism. They're more at risk for developing clots again in the future. So it is these long-term effects that we need to prevent the first one so that we don't have patients who have these long-term effects. Patients who have a pulmonary embolism can have chronic thromboembolic pulmonary hypertension. So that can create actually loss of work, not being able to return to work after an event happens. So it can lead to permanent disability. So this is a CDC infographic, actually for patient consumption or for healthcare consumer consumption. It again talks about the blood clots, how many patients it affects. The big thing on this slide is, though, that 50% of blood clots are healthcare associated. So this is a really big number that we can have a huge impact on for those of us who work in the acute care arena. Healthcare-associated VTE, or HAVTE, is the leading cause of preventable death in hospitalized patients. About half of all of VTE events, as I said, are related to a recent surgery or hospitalization. They usually occur after discharge. So this is really important to know, that our nursing staff and our hospital staff aren't going to see these events. A lot of them are taken care of in the outpatient arena. So it's important to make nurses and other hospital providers aware of how big this problem is, because they're not going to see it in their day-to-day life. They do affect all-cause readmission reimbursement. So if a patient has a knee replacement and then comes back into the hospital for a VTE-related event, the hospital will not be reimbursed for that event, just like they're not reimbursed for pressure ulcers or hospital-acquired infections. We do know that 70% or up to 70% of hospital-acquired VTE are preventable. So this is where we really can make a difference. We can use pharmacologic prophylaxis, mechanical prophylaxis, and one of the big things, and I'll share more with you in just a few minutes, fewer than half of our patients receive recommended prophylaxis. So there really is room for improvement. Now, we all know that the Centers for Medicare and Medicaid Services have changed their meaningful use guidelines, and they do have core measures where hospitals will not be reimbursed unless we show that we are at least attempting to do VTE prophylaxis for our patients. But what I'm going to show in the future slides is that even though we have orders for them, our goal is to make sure that these orders are adhered to. So it doesn't just stop at ordering the protocol or having a protocol. It's making sure that that protocol is carried out. So I have a little poll for you as we get started. What factor would you think would most increase patient adherence to mechanical VTE prophylaxis? Would it be the availability of equipment, more comfortable or cool sleeves, patient compliance meter in the equipment, so the equipment telling you how often the patient is using it, nursing education and documentation, escalating when patients decline treatment, patient education, or multidisciplinary rounding, or if you have another idea that would increase patient adherence, please let us know. I'll give a couple more seconds for everybody to get their answers in. Okay. Oh, so almost 40% of you said, or 40% said patient education. And I agree, patient education is huge. And we will talk about that later on. The availability of equipment, more comfortable or cool sleeves. A lot of patients decline wearing them because they're uncomfortable. But I think that patient education is what's going to get us moving forward. So let's talk a little bit more about that. Thank you, everybody, for your engagement. So non-adherence, there are so many examples of non-adherence to VTE prophylaxis found in the literature. And this is what I found really surprising. Patient refusal of pharmacologic or mechanical prophylaxis occurs in about 8.5% to 18.2% of pharmacologic VTE prophylaxis. This was so surprising to me when I was doing this research that up to 18.2% of patients are not receiving the medication that is ordered for them. And it can be for multiple different reasons. A study on mechanical VTE prophylaxis in 2017 found that improperly placed or no mechanical devices on up to 81% of trauma patients. These numbers are staggering. So we can have those things in place where this is what we should do, but we need to make sure that that's what we're doing, that we are carrying this out. So 25% of surgical patients and 51% of medical patients did not have pharmacologic prophylaxis. So let's take a look at what you think. Does your facility have a VTE committee or a PE response team? I neglected to mention the beginning of all of this was my facility initiated a pulmonary embolism response team. And the VTE prophylaxis committee was an offshoot of that pulmonary embolism response team. So we are a member of the PERT Consortium, which is an international body for pulmonary embolism response and treatment. So looking at treatment goals. So how about all of you? Do you have a VTE or PE committee? Wow, 57% said no. So there obviously is a lot of work that we can do and a lot that we can achieve. And this is one of the really great ways to start that. 42.6% of us do have a VTE or a pulmonary embolism response team. So that's great. We can build on all the efforts that we're doing. Oh, excuse me. So creating a VTE committee. And as I said, our committee is based off of it's a subgroup of our pulmonary embolism response team. So you want to identify who your key holders are. You want a multidisciplinary approach. So having leadership and executive champions that will help you with any kind of meeting preparedness or having some time for people to go to meetings. Definitely need help from our pharmacy providers, our nursing, physicians, and frontline staff. The frontline nursing staff is a really big part of any kind of VTE committee, just to make sure that we're reaching those people where they are and that the things that we put into place are the right things to do. We also want to have a patient education arm and a patient advocacy group. I know most hospitals have a group made up of former or current patients that kind of talk about what kind of education initiatives they would like to see moving forward, or what kind of things we can do to improve a patient's hospital stay. So patient advocacy is a really great way to get more people involved and make good decisions. We need a committee structure. So having goals and objectives for each meeting, and take a look at those goals either annually or quarterly or on an as-needed basis. Having meeting minutes so that if you do have an actionable item going forward from meeting to meeting, you can follow up on that at the next meeting and send meeting minutes out. This is one of the biggest things that I think will help is dedicating time and consistency. So even during the COVID-19 pandemic, a lot of our work started before that, and we were kind of put on hold a little bit because of the pandemic. I was working as the nursing educator, but then because we had such an influx of patients, I was also working as a registered nurse, taking care of patients with COVID-19. So sometimes the meetings had to be way late a little bit, or we had to make them short meetings. We did take a little hiatus, but we did then jump back on and start dedicating time so that we know that on the third Thursday of every month, we get together for this amount of time to discuss VTE prophylaxis. And even if the meeting was, guys, I've been really busy, I haven't been able to get to that today, you still had that placeholder to have that those meetings. And then so that helps to sustain momentum between meetings. Another really big thing is dealing with competing priorities. I know we're all looking at the multitude of hospital improvement things that we do every day with, hospital-acquired infections and other forms of things that we look at in our hospitals. So one really good thing is you can think about tagging on to other groups that are already meeting. So does your wound care group do a wound prevalence study every so often? Could they look and do a point prevalence on how many patients actually have their mechanical devices on? So, the nurse may document that the patient has it. Is it on or is it just at the bedside? So you can kind of pull in even your wound care group to do that when they're doing point prevalence, or if you're doing a urinary catheter point prevalence study, looking at that. But I would say one of the really big things is to start with a gap analysis. Where are you right now? What protocols do you have in place right now? Are they being adhered to? Where is the nursing staff? What level of education do you have for both the nursing and pharmacy and your physician or provider group? And so looking at where you are. And also, do you have a specified VTE risk assessment tool? And is everybody using that same risk assessment tool? And how does that work in the workflow? So another poll for you. Do you think there are enough people who support and champion VTE prevention at your facility to be successful? Do you have enough people to meet the goals of your group? All right, that's great. 51% said yes. We do have challenge with 48.1%. And you'd be surprised who you can find that are really engaged and excited about working for these towards these goals. If your nursing department has a staff development ladder or a ladder where they get a promotion or a higher level for being in certain groups, or if you have that as part of your annual evaluation, how many groups somebody is involved in. Those are some ways that you can kind of get more people in and rein people in and help them, get more champions engaged. So knowing your current state, as I said, that gap analysis. What are your protocols currently? What do your order sets look like? Do you have a specific VTE prophylaxis portion of the orders? What are your assessment tools? And then how are those orders carried out? Is there any kind of backlog or issue between the pharmacy review and input, or the pharmacy reviewing the orders? Do you have a way that the pharmacist can say to the provider, let's look at this patient's renal function and maybe take another look at this pharmacologic prophylaxis? Do you have enough devices available? And not only the devices, but the sleeves as well. Are the nurses kind of taking off that order and checking it off, but then not putting it on the patient because they can't find a device? And then the documentation. We have done a lot of work at kind of prompting nurses to sort of do the right thing through the documentation. And we do the same thing with the physicians and provider group. When they have that documentation, it kind of gives them a little tickle to remember to look at certain things. And then, as I said, look at your adherence to prophylaxis orders. Look at your rate of refusal and provider notification of non-adherence, and have backup plans. So one thing that we found was that our providers actually came to us and said, I didn't realize that my patient had refused this medication for 4 days in a row. So then we went back and talked to nursing about, what do you do once a patient wishes not to receive a certain medication or wishes not to utilize a mechanical device? Where do we go from there? And kind of having that escalation or having those plans of what to do when the patient does not want to comply or adhere to the orders that were set forth. So this is a very quick raw data from my institution. And what surprised me was that this was very much like the literature that I had looked at. So this is a medication not administered by drug name. And this is for every administration time that they could have. So if it was dosed at 2 times a day and they were there for 5 days, this could be out of 10. I want you to throw out the second column there, the Erixtra. We had a very small number, and it's something that we don't have exact doses on formulary. So that one's a little bit, so full disclosure, that one is not really as correct. But the important thing to look at on this is those blue lines for Lovenox and heparin. Those are our parenteral medications. Those medications where the patient has to get stuck, has to get a subcutaneous injection for. Those were definitely refused a whole lot more than all of the oral medications. So that's something to look at with, if the patient is refusing that, is there something else that needs to be done, or do we just need to talk to them some more? One of the research studies that I looked at showed that if a patient refused a medication, or I shouldn't say refused, but if they did not wish to receive a medication on Thursday, then the nurse coming in on Friday tended not to even offer it. So it's really important that nurses know that these things, excuse me, I'm sorry, let me back up one. So it's important that nurses know that we need to escalate the education. So if they refuse it today, then move on and see if tomorrow, keep offering it. And I'll get a little bit more into patient education in just a few minutes. So for our mechanical devices, this is again from my hospital, and I'm comfortable sharing this because this is really what was in the literature. It shows that we're not different than other hospitals, and the original literature that I looked at was from Johns Hopkins. So So this looks at device on at the documentation level. So again, if they could document twice a day for 5 days, that would be 10 documentations. And out of those times that they could document, 19.9% of time a patient refused. And then at the visit level, at least once in the hospitalization, 37.5% of the patients at least once in hospitalization did not wear their mechanical device. So that's where I come from saying, yes, it can be ordered, but we need to make sure that it's actually on, that it's actually being given to the patient or that is actually on the patient. So what should we do with this information? Find areas for improvement. Look at your policies and protocols. Is there a gap somewhere? Is there something that can be made easier? Something in the workflow that can be changed? And then when you find those areas for improvement, small tests of change or that action research, maybe starting on one unit and really focusing on one nursing unit to look at what can we do? And if it works for them, then move it forward through the rest of the facility. And then, as I said earlier, that committee action items and follow-up, it's difficult. It's difficult when you have competing priorities to follow up with each actionable item. So maybe having a meeting in between where you just follow up with people that are on the committee and say, hey, how are you doing with those patient education videos that we talked about? Or how are we doing with the data? Are we able to get the correct information that we need? So that meeting a little bit in between and following up on items in between committee meetings is a really good idea, especially for nurses who are frontline, because they might not be focusing on the VTE prophylaxis committee because they're really focusing on their patient care for that day. So just following up with them to kind of refocus things a little bit. So what resources can we find? What resources are out there? There's many really great national guidelines. VTE specific are the CHEST guidelines. These have not been, these are actually from 2002, I believe. So they have not been updated recently, but there are other guidelines from the Hematologic Society and also surgical guidelines. As I showed earlier in the presentation, the Centers for Disease Control and Prevention, those are really great place to look at the data and the statistics that are out there, but then also they do have toolkits. Our peer-reviewed healthcare literature, of course, we always want to look at our journals and our professional organizations. So the Society of Critical Care Medicine or the orthopedic surgeons groups. The CHEST is developed by the cardiac surgery and intensivist groups. And then we can also look at quality improvement agencies. So the Institute for Healthcare Improvement, they have a lot of open classes where you can learn about action research and small test of change. Another one is the Agency for Healthcare Research and Quality. Some of these you can input your data and compare yourself to other hospitals, like hospitals. Healthy People 2020, which is updated every 10 years. There is a guideline for hospital-acquired infections or hospital-acquired conditions as part of Healthy People 2020. And as I said, toolkits are available on many of these sites, things that you can use for your point prevalence days, and also what data do you want to collect. Some other resources, the Joint Commission. So what is required for our accreditation? And then meaningful use incentives. Will we get better reimbursement if we make sure that this is done? So what is kind of the baseline that we need to do? And then we can, kind of build from there and find out what works best in our institution. Another place, and this is how I got a little bit more information, is your healthcare industry sites. Your device companies and the pharmaceutical industry might have a little bit more resources, and they have that focus on that specific disease process. So they may have resources or some videos or educational tools that are right there and available so that you don't have to make things from scratch and you can kind of save time. And because they have a little bit more resources, they may have a better production quality than something that we can develop ourselves. So your VTE prevention protocol, you can also look at technology-based resources. So most of our providers know a lot of the MedCalc or MD Calc, which has calculators. What we decided to do was actually add that into our electronic health system. So have those tools right there at the provider's fingertips, so it's easy to fill those in and do those risk assessments as part of their workflow. And then have orders generated from that risk assessment. So you have that risk assessment that comes up, and then have that say to the provider, listen, this is what we recommend. And then a really important thing is reassessing patients during their stay. So if they came in at one level of care and now they're transferred to critical care, to an ICU level of care, their VTE prevention practices have to change, because there's different risk factors for a critical care patient rather than from a medical surgical patient. Another technology-based resources, and this is something that we are working on right now at my facility, is patient education videos. We have a very robust patient education system where on the television that is in their room, we're able to push a video to them, and it comes up as, this is something your provider, your healthcare team wants you to look at. And when it comes up as kind of a notification with that little red dot, the same way that you get on your phone, the thing that you always press because you're used to, it's that thing in your brain that makes you want to get rid of that little red dot. So we have videos for our patients, and what we're looking at is having education videos on VTE prophylaxis for every patient that comes in. But then if they decline treatment for VTE prophylaxis, maybe we send them another video that has a little bit more information. And then they're hearing it from multiple different sources. It's not just the nurse that's taking care of them. It's not just one person telling them. They're actually seeing something from a large agency that's saying, this is something that really is important for your care. And as I said, protocols. Build your protocols into your workflow. Have the provider order generate communication to central supply if you're able to do that. Or have your prophylaxis devices right there on the unit so that nurses can find them easily. Pharmacy verification. Is there anything that can help the pharmacist out a little bit better? Do they need to go through and make a lot of adjustments to a provider order to get it into the nursing workflow? Or is it a little bit more seamless? So is it easy for the pharmacist, or is it a little bit more difficult? And anything that's getting more difficult is going to kind of delay care and delay the patient getting what they need. Nursing education and documentation. So we just built into our documentation reason for refusal and provider notification, just as a reminder to the nurses, hey, you might want to let the doc know that the patient is not keeping their VTE devices on. And then what the literature showed was actually that multidisciplinary rounding was one of the best ways to increase nursing education and increase the nurses' willingness to kind of move the patient forward to adherence. When you do that multidisciplinary education, you relieve that barrier of, I think they were just checking this box off, or they have to order this for everybody, but this patient doesn't really need it. Whereas during multidisciplinary rounding, you can have a conversation with your intensivist or your hospitalist to say, are you sure you really want to do this? The patient is uncomfortable with getting an injection. Can we find something else? And then you get buy-in from all members of the team. And that was found in the literature to be one of the best ways to increase adherence. And then patient education. The CDC has some pre-printed infographics. You can do a campaign or have a poster in the patient room. And again, those patient education videos can be really good as well. So what do you think in your institution is most needed to improve your VTE prevention protocol? How do you think you can improve best in your facility? Would it be institutional support, multidisciplinary team leadership, standardized risk assessment, escalation protocol for non-adherent patients, reliable data collection and performance tracking, or do you have some other way of increasing VTE prevention? I'll give you another minute, another few seconds to get your answer in. Great. Yeah, these, so when we developed these questions, some of it was all of the above, and I think that all of these are important. But looking at that multidisciplinary team leadership is a really great way. Maybe each person taking a different piece of the pie, and nursing working with nursing, and pharmacy going to their peers and saying, is anything holding you guys back, or is anything holding you back from getting those orders in for the patient? Data collection and performance tracking is huge. Our quality improvement group, I could not do anything that I do without them. They are so dedicated to improving patient care and getting us what we need. And working really closely with them is just a godsend for me. They really help me figure out what we need to target. Because if you have the data and you know that you're doing well in one area, that frees you up to focus on your more challenging areas of performance. So data collection and performance is really, I agree with the members in the group that feel that that's needed. Standardized risk assessment. Is everybody looking at the problem in the same way? Or is every patient getting the same type of assessment, at least in your institution, so that when care is transferred to another group in the hospital, everybody knows how that patient was assessed, what tools were used, and then that escalation protocol for non-adherent patients. As I said earlier, if a patient refuses one day or it declines treatment one day, having more people discuss that with the patient and offer that to the patient is really, really going to help maybe change their mind. Maybe the first person, they don't really hear it. The second person, they don't really hear it. By the time they hear it from a third person, they might say, oh, wait, maybe this really is important. Let me think about this a little bit more. And then institutional support obviously is important. We need to have that support from our higher level leadership. Okay, so what do we do with achieving goals? So as I've mentioned many times, having that availability of equipment, ensuring patient adherence by escalating doses of education. And that doesn't necessarily mean that today the nurse speaks with the patient, so tomorrow it needs to be a physician or a provider. It can be every single nurse that walks into the room. So instead of getting just one dose of education, the patient is going to get a dose of education on these things every single day. And then informed refusal. This is something that we really should think about a little bit from a healthcare perspective. We talk about informed consent, but we need to talk about making sure that the patient knows what will happen, or what could happen, what could happen if they do not, or if they decline that specific treatment. We did have a patient, an issue with a patient who had refused or had kept taking off their SCDs and didn't want to wear them. And so the nurses documented every day that the patient did not have them on. And then the patient actually developed a DVT. And when the family looked back and asked us, what did we do for VTE prophylaxis? I thought that the patient was supposed to have that while they're in the hospital. And we said, well, your mom refused to wear these devices, or, did not want to take this medication. The family came back and said, well, mom is, she has early dementia. She really doesn't understand everything that's happening. So we have to think about, being a little paternalistic in that way, and really showing the patients everything that they need, and thinking about what that refusal means, and maybe pushing it a little bit. And I'm not saying you just do things to patients when they don't want it, but really informing them of all the risks of declining certain treatments. And feedback or data. Celebrate achievements, review challenges or barriers. Celebrating achievements will always be a really big thing, of course. Automated reports to committee members. I complain a little bit that I get reports every single day, but I tell you, those reports really help me improve patient care. I can see every day which patients do not have devices on, or a device that's ordered but the patient the nurse hasn't documented that it's on the patient yet. The same thing with pharmacologic prophylaxis. I get a report every day of how many doses of anticoagulation or VTE preventative medications are not given. So then we can go back and talk to the nurse or the patient and see why why those treatments are not being given. So moving on a little bit to learning in a digital world. The pandemic has showed us so many things, and even this webinar right now is one of them. I had been to a few webinars prior to the pandemic, but most of my learning was in person. And this opens up so many opportunities. And if there's anything that I would say that I like about the pandemic, or any good, there's a lot of good that came out of it. But one of the really good things is it has brought us together in this way, using digital media that has always been around and has been so powerful, but now we're actually engaging in that. So we can reach out to so many more people. We have people today from all over the United States. And it's really great. We can all get together and discuss ideas and also engage in learning. So clinical education, specifically for nursing, can be difficult. The dynamic working environment, nurses work 12-hour shifts. They have very little downtime. So what we have done is look at education credit when possible, and look at the digital media where they can receive that education on their own time. Bringing it home, so personal story or case review, speaking about that patient who was not adherent to their VTE prophylaxis while they were in the hospital and developed a DVT or even a pulmonary embolism. So we are actually looking back at our pulmonary embolism patients to see if they have had a recent hospitalization, so that we can tell the nurses, this patient that you took care of on such and such a time developed a PE, and then what happened with that? Did they survive or did they not? But having those personal stories are really meaningful to all providers. Prioritizing education initiative. So is there one thing that you can focus on this year or this month? So having those annual performance improvement plans and really focusing on that. And you can pull in things from other areas as well while you're looking at one thing. Offering continuing education credit. I know physicians, pharmacists, nurses, respiratory therapists, we all need continuing education credits to maintain our license. And then also if we have a specialty certification, you need even more. So having those continuing education credits is always a plus. Embracing social media. So we don't have this where I work right now, but I was in a group with a previous hospital. We had a Facebook page just for our unit. I know some places also do group text messages. I feel like you shouldn't do those messages that go out to everybody. That's not really fair on days off. But a social media group where you can kind of engage when you want to is a really great thing, in having information right there when it's good for that person that is looking at it. And then digital learning, online modules. We have a learning management system, and I know most places do. The learning management system where the educator, like myself, can assign certain learning opportunities and have CE opportunities. So you have a certain amount of required learning, but then also have that learning out there that they can choose other ways to learn. Webinars like this one. What they have found in the literature is that dynamic, interactive, learner-centric education is really key. So if you have a learning management system, a learning opportunity like a module, an online module, something that the nurse can engage with, or that the attendee can engage with, like the polling questions that we've had, it's something that makes it a little bit more interactive, really engages people and will help increase learning. And then we are looking at just-in-time education. So those multidisciplinary rounds, that's just-in-time education, really talking about things right at that moment. I'm also doing my capstone, my MSN capstone on QR codes. So doing really fast bursts of education where you just take your phone or a scanner and click on a QR code, and that will give you really fast access to short bursts of education. And that doesn't have the CEs, the continuing education credits, but it is that really fast education right when the nurses need it. They also have that for patient education. So that was a little slip up, but it is true. There's a lot going on in physician waiting rooms and things like that, where they can hit their QR code reader and use their phone for good, instead of just kind of mindlessly looking at Facebook. Okay, so another poll question. Which of the following learning methods do you prefer for continuing education? Do you like those learning management systems where you have assigned modules or catalog of items that nurses can self-enroll in? Would you prefer webinars, conferences, online learning activities, including through professional organizations? Or do you feel that in-person training, skill sessions, didactic learning, do you prefer that? Or there's also print articles with continuing education credits. Or do you think kind of a mixture of all of the above is best for continuing education? All right, I'll give you a few more seconds to get a couple more people in. A mixture of all of the above. Yeah, find out what's best for your institution, for your nurses, or for any of your providers. Meeting people where they are and kind of giving them a mixture and offering those different things. That's really great, and all of the above answer. But the webinars, conferences, reaching out to those professional organizations, having those that online learning activities, those work really great. I admit that I use those learning management systems. That's the easiest way for me as an educator to make sure that the nurses get the focused education that they need. And a lot of them do use the catalog of items for self-enroll, but that is so widely based. So I think those conferences and the professional organizations kind of bring it into that learner's perspective, and we'll have the things that are specific to their role, like as a critical care nurse or as a pharmacist. And the in-person training, I feel like nothing beats that. Even in this digital world, I do miss meeting with people and seeing them and being able to ask questions in real time. So I can see the benefit of all of those. But it looks like, hands down, a mixture of all of the above, and kind of finding out what everybody needs is probably the best way to go. So what can we do with digital information? What kind of things can we put out there? You can have huddle scripts so that at your morning huddle or during multidisciplinary rounds, you're kind of saying the same thing for multiple days in a row. You can have formal improvement campaigns, having something in every patient room, and every nurse knows that we are focusing on skincare or hand hygiene, or maybe all of the above, VTE prophylaxis. And then performance monitors like dashboards. One thing that we've done for some of our order sets or things that we wanted the physicians and providers to look at was we kind of make them compete a bit against each other and say, hey, look at this, you guys, Dr. So-and-so does VTE prophylaxis on 90% of his patients, whereas, this one here does it, 10% of the time. Physicians and providers are so competitive. They will definitely get involved in that. Having performance monitors at that unit level. So looking at each unit individually and seeing, well, this is our really high performing unit. What are they doing? And can we move that into one of the lower performing units? Monitoring and reporting adverse outcomes. You do have to report hospital acquired VTE, and look for bleeding. And if you're seeing bleeding, let people know. Be really, really transparent with that in saying that this is how many bleeding incidents we've seen. So we should look at, looking at a better bleeding risk assessment. Patient education. So again, real-time alerts when patients miss VTE prophylaxis, and that targeted patient-centered education. Maybe offering them a little bit more of those videos or nursing education or education from the nurses. And this is my list of references. You can find some more resources at cardinalhealth.com, no VTE. And I'm going to open it up for questions and answers. And at first, I want to thank everybody for your time and attention and your engagement with the polling questions. I really appreciate your time. I'm going to
Tanya, congratulations on an excellent presentation. And on behalf of everyone, thanks again for all of your outstanding efforts caring for patients during this pandemic. As Tanya mentioned, we'll now be moving over to the question and answer portion of the session. As a reminder, you can submit any questions you have by typing them into the Q&A box you see on your screen. Tanya, a number of questions have come in, and we've bucketized them into different themes. To set the stage for a lot of the answers, a lot of folks were interested in knowing what is your electronic health record system, because I think that will frame out some of the responses. So maybe if you could just quickly respond to that, and then I'll provide more questions for you.
Sure. So we use kind of a not widely used system. It's Meditech. One nice thing is it does have best practices built in, but it's not a huge system like Epic. One thing is that we are able, because it's a smaller institution, we're able to really personalize it and create documentation sources that we want to have for our nursing documentation. So we're really able to really alter that documentation system to make it our own. So we use the Meditech system. I'm not sure how easy that is in other systems, but that's the one that we use.
Great. The first bucket is around patient adherence, or I guess you could also say non-adherence to therapy. Ken, Sylvia, some other folks were wondering, what do you do with patient non-adherence, or do you have an audit tool to evaluate adherence or non-adherence? Maybe let's stick with mechanical prophylaxis. Could you comment on that?
So we don't have an audit tool. We do have that daily report that is sent out that shows if a patient has the devices on, and that's based on nursing documentation. And I would say find out why. What is the reason that the patient is non-adherent? And I really think it starts with getting nursing buy-in for how important VTE prophylaxis is, because if the nurses buy into it, they're going to educate their patients on it. And they're going to do a really great job of steering the patient in the right direction. If it's a complaint about, it's making me too hot, or they're too tight, or I can't get up and walk as much, then those can be talked to at the patient level or discussed at the patient level. But there are some devices that actually have cooling devices in them so that they're not as hot on the patient. Maybe that patient needs a different size sleeve because it's rubbing up against the inside of their knee or something like that. So having the right fit or trying other options. And sometimes it's just, really finding out, meeting the patient at their level and finding out what's going on with them. And then it's also the knowledge that, I know that you want to get up and walk around, but when you're in the hospital, you're not walking around enough to really prevent VTE.
Great. Tanya, the next theme is around risk assessment. So I guess we're backing up a little bit as far as the standard cadence of how you manage and prevent VTE. Some folks, including, let's say, Amanda, Yasmina, and others, were asking about what electronic risk assessment tool or what risk assessment tool do you use in your facility?
We have the Padua risk assessment built right into our electronic medical record. At the moment, the physicians are not, or the providers are not required to fill in the risk assessment, but they are at least required to document a reason for why they chose one method over another. So for instance, most critical care patients really do need pharmacologic prophylaxis. So if the physician doesn't order that, we were kind of, we got to the point where we were saying, well, why wasn't this ordered on this patient? Is there a bleeding risk that we don't know about? And it was kind of taking up our time, and we were losing some efficiency. So we built the Padua risk assessment in there. If they fill it in, we can look in and see why they made the decision that they did. But if they did not fill it in, they are at least required to document why they chose one method over another. So we use the Padua risk assessment tool.
And Tanya, how often are you updating the risk assessment? Are you doing that daily, once a week, or at condition change?
It's on admission and then on condition change. But I will say when we do multidisciplinary rounds, especially in the ICU, it's ongoing. So every day our pharmacists are really wonderful about bringing up VTE prophylaxis and really looking at all of the conditions that are going on with the patient and what can we improve? Do we need to change anything? So usually it is with admission and change in level of care, but I will say in the intensive care units that it's a daily assessment.
Great. Tanya, maybe you could talk to us a little bit more about education and guidelines. I think you may have mentioned the CDC has patient education videos. And also maybe more specifically, where can an audience member start to find some guidelines to kick off a VTE prevention program?
So, the best guidelines or the most overarching guidelines are probably the one that are in CHEST. And that was a supplemental edition that just has VTE prevention guidelines. It is hard to kind of go through that. You're talking about, 30 pages of guidelines. I'm sorry, I don't know the exact number for the CHEST guidelines, but it is a lengthy document. So I would say, as I said, the CDC, but looking at the guidelines of what is the minimum that your reimbursement is looking at, or the Joint Commission, what are they looking at a minimum to have for each patient? And then think about what you want for each patient. And those calculators will say if the patient should have, mechanical prophylaxis versus pharmacologic prophylaxis with looking at bleeding risks. So I think the documented guidelines are probably some of the best ones. But then I found that on some of the industry sites, like the Cardinal Health site or some of the pharmacy sites, they have a little bit more kind of broken down into language that's very quick and easy to understand for any healthcare provider, without all of the it breaks it down a little bit easier for you into easy to read and easy to digest information.
Great. Tanya, maybe we'll take one more question here. There's a theme around different devices. Jill asked about the compliance meter on SCDs to measure compliance or evaluate compliance. Jonah asked about maybe just erring on the side of caution with regards to different levels of risk, and at least maybe requiring all patients at some level of risk to be prescribed SCDs. Could you provide some comments there?
Yeah, so I think those are great information. Bill, I'll let you talk a little bit more about, compliance for, how long patients have those on. I know that is a part of some of the devices. I know, we have beds that will tell us how long the patient was at a 30-degree angle, during how much of the day. So I'm sure that these devices have it, and those smart compression devices. I don't know as much about that specifically. I am sort of in agreement with the have it for everybody. And actually our vascular surgeons are also in agreement with that. You do get a little bit of crying wolf. If you have it on everybody, it loses some of its meaningfulness. So, it's kind of like that checking off the box. I'm just going to check this box and make sure that it's done. Sometimes it loses the meaning. And then people who really, really need it may not get it because it's just kind of, a base level. There also is the part of, it could be a habit to have it on everybody. So you put it on everybody. But I think that there is a degree of meaningfulness when you have it on everybody. Then you don't focus on the people that really need it as much. I don't know if that rings true, for you, Bill.
Great. Yeah, I completely agree. Now, just to address your comment on compliance, I would encourage folks to visit the cardinalhealth.com/NoVTE website to learn more about compliance. I do want to respect time. I know we're at the top of the hour here. So Tanya, again, thank you for an outstanding presentation. We're delighted with the delivery. The questions that have come in have been fantastic, and we're really excited to be following up with all of the individuals here. And I'm going to turn it back over to Beckers and Brian to close us out.
Yeah, absolutely. Thank you so much, Tanya, for that excellent presentation. And thank you, Bill, as well, for your contributions. And thank you, Cardinal Health, for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.